The EMS Avenger podcast is sponsored by Zoll.
Well, the clinical relevance is this. Those conduction pathways, those roads are living, breathing cells.
Yeah.
And so what makes living, breathing cells mess up? Lack of oxygen. So diagnosing a hemiblock, diagnosing a bundle branch block is an acute coronary syndrome because a coronary artery is causing that to happen. And so see, when you talk about differential and someone's got chest pain and they have that block together, you know that's significant. It takes a large amount of blood supply that's going to be missing, for that to occur.
I'm Jimmy Apple. This is the EMS Avenger podcast, and I am here with Bob Page. And I know I have learned a tremendous amount from Bob Page, and most people who are in my generation, essentially, Bob Page is to me as I am to a lot of people, which is like one of the first EMS influencers that I ever encountered. And Bob is the author of MultiLead Medic, Slap the Cap, and is involved in a whole host of projects right now. But Bob has really influenced EMS in positive ways, particularly with the use of capnography and also with the enhancement of people's awareness of cardiac practices and how to interpret ECGs. And it all stems from one thing, and I've talked about this, which is a patient that had an unfortunate end because of an action that was taken that Bob was responsible for. And Bob and I had a conversation about this, and it involved scars. This is a scar that you carry in EMS, and I just want you to tell me about that scar and where it led you in EMS.
That's a good point. And scars are a big part of it. Sometimes you might call it motivation or reasons or motivations for doing a certain thing. For me, it was back in 1983 where I first found out that I didn't know everything like I thought I did. So young paramedic, 3 years out of school, I thought I knew everything. I got a call for a guy with chest pain. So he showed up, and I'll never forget this. I walk in the house, and the guy's sitting on the couch, drenched in sweat, rubbing his chest. And I go, "Hello, sir. My name's Bob. I'm a paramedic with the fire department. What's your name?" He goes, "Hernandez. It's Mr. Hernandez. What's going on?" He goes, "Senor, my chest, it hurts so bad. I think I'm going to die." I go, "No, sir, you're not going to die. I got you. How's the breathing?" He goes, "That's not so good neither." Well, I was 11 easy call. He said, "I had the magic word chest pain, and I got a protocol for that." And back in the day, they told us they had chest pain. We're supposed to vomit on them. Vitals, oxygen monitor, IV transport. And so I said, okay. So I put him on, gave some vital signs, put him on some oxygen. Then I put him on the monitor, and I saw a normal sinus rhythm and a couple of the PVCs. Now, back in the day, that was a sick patient right there. In fact, we had sayings for that, right? More than 6 a minute, R on T, by Jimmy, China Jimmy, Fort runs of VT, multifocal couplets. Well, you had a couple of PVCs, and of course, back in the day, if you had a couple of PVCs, you were suffering from one condition, and we called that hypolidocaemia. Low blood levels of a drug called lidocaine.
Right.
And so I'm a prudent paramedic. What did I do? Well, I was going to give him some. But before I did, I asked those questions that we all got to ask. I said, "Mr. Hernandez, you allergic to anything?" He said, "Nope." Said, "You allergic to any medications?" He says, "Nope." Said, "You ever had Novocaine before at the dentist?" He said, "Oh, yeah, see." I said, "What'd it do?" He said, "Made my mouth all numb." Cool, that's what's supposed to do. I'm going to give you that same drug right now to settle down that restless heart of yours. And so right in front of the Lord, his wife, and everybody, I gave him that drug. And after 3 minutes, I bossed his PVCs and everything else he had.
Mm-hmm.
I put that man in stone cold dead, flatline asystole. He fell over. His wife screamed. I screamed. "Ah!" My partner goes, "What?" I said, "Get the cot," which is a universal sign of a paramedic in a Charlie Foxtrot, right?
Right.
And so we got the cot, and we threw him on the cot. And we're heading out to the ambulance. I walked beside the cot trying to do compressions, but that junk don't work. But let's get on TV, doesn't it? So I jumped in the back of the ambulance. My partner jumps in there with me and says, "Bob, what do you need?" I said, "I need you to drive real fast because I've lost it." So I'm in the back doing compression. And you know what, Jimmy? I found myself going through them 5 stages of grief.
Right.
That Kubler-Ross thing.
Yeah.
And I'm going to get to acceptance before I get to the hospital. Watch me. And so I remember I hollered up front and I said, "How far out are we?" My partner turns around and yells back, 45 minutes. Yeah, they ain't no way, And so, they told us to do CPR till you can't do it no more, right? I never thought I'd go there as a paramedic because I always had a partner to help me. Well, guess what? He's driving the truck. So I'm all alone now, Wells, and I reckon I lasted about 15 minutes, and I couldn't feel my arms anymore. Now, I don't know if you've ever done it so much you can't feel your arms anymore, but I went there. It ain't much fun. So you know what I did? 20 minutes outside the hospital, I exercised my prerogative as a medic, and I called the code. I was exhausted, man. I couldn't do another push. And so I remember calling the code, taking a deep breath, looking at the monitor, praying that something's on there. It's still a flat line. And on a LifePak 5, that's saying something. So, LifePak 5, you always have sign stack with artifact, right? Well, you guys use the LifePak 5, you know what I'm talking about. If you ever use LifePak 5, shout out. By the way, the LifePak 5 is in the Smithsonian. It's in the Museum of American History.
Wow.
So anyway, I'm a museum piece, right? But anyway, so like I said, I gave him a lidocaine, went into asystole, and I called the code, and I remember looking through the protocol book to find out where I screwed up at. And I found the chest pain protocol, so I went down the protocol, said I did that. Yeah, I nailed that protocol, but the dude's still dead, so it's not my fault. He should have read the protocol. I follow a protocol written by a board-certified emergency physician, licensed practice of medicine in the state of New Mexico. I did everything I'm supposed to do. He didn't read the protocol while he did. So I did, I felt pretty good because I didn't think I violated anything. Then I kept flipping through the protocol, found another protocol, and I go, dang, how could I miss that? So to cover my butt, I reached in a drug box. I gave him 3 more drugs. I gave him D50, Narcan, Thiamine.
The coma cocktail.
Yeah, he still didn't wake up. I'm out of drugs, and the dude stayed dead. So we get to the hospital, walk in the door, and the doc looks at me and says, dang, Paige, what happened? I said, I don't know, doc, this is what he had. And he goes, well, that's some significant ectopy. I go, yes, sir, it was. He says, what did you do? I said, I followed my protocol, gave him lidocaine. He said, then what happened? I said, well, he died. He said, I can see that. How long after lidocaine did he go out on you? I said, I say about 3 minutes. And the man's facial expression changed. He dropped his head and went, oh. I said, oh, what? He says, Paige, you probably had a heart block. I go, he ain't got no dang heart block. I can read. He says, no, Paige, a block in his ventricles that you can't see. You need to have an electrocardiogram for that. I go, that's what this is. He goes, no, it isn't. This is a rhythm strip. It's a lead 2 rhythm strip. Didn't they teach you anything in that paramedic class you took? A lead 2 rhythm strip tells you nothing about the patient.
Lead 2, have no clue.
Right. And that's what he said. And so that's how I started that. So, and I thought to myself, I just killed a man out of ignorance. There's something I did not know. Then I snapped to attention. It ain't me. I ain't no senator son. It ain't me. Because why? I was a top grad in my medic class, really aced the registry exam. I got letters in my file from doctors saying I'm a good medic. You know what else? I'm an ACLS instructor. So me not know? I don't think so. He said, that's right, Paige. That you didn't know, and that man's dead because of it. Dang, man, this ain't good, Mav. Had to see what condition my condition was in.
Right.
And so I learned something that day, and I started a program. It's called MultiLead Medics, and I learned that day that in lead 2, you got no clue. And so you remember that same phrase.
I do,
I'll never
yes.
forgot that. And what that means to say is, yes, you can use lead 2 to read VFib. So when you put them on a monitor, it's just a monitor. I'm just a monitor. I can only tell you when they died. They just died. But what if you run a 12 lead first and can find these conditions I was even told to look for? Jimmy, I killed that man out of ignorance. It's not what you don't know. It's what you don't know is going to hurt somebody.
That's right. The example of the Dunning-Kruger effect. You don't know what you don't know.
Right. And so if we want to learn that, we have to go beyond original programming. We have to go beyond that and see what it is we're missing. And so ever since that time, actually I took a day off, and I took a week off because I didn't know what to do. I was ready to quit because I thought I knew everything. Then guy died by my hand, and that left a scar. Mm-hmm. That left a big scar. And so what do? You try to prevent that from happening again. So what I learned from myself, and that was that week after that call, I went on vacation, went to Disney World in Florida, and I was about to get on the monorail, go to the Magic Kingdom, and I heard this loud applause from me in the Polynesian. So I turned around, there's a bunch of suits and scrubs filing into a conference room. So I walked down there to see what all this was about, and there's a sign outside that says, today only, Dr. H.J.L. Marriott on bundle branch blocks. A little small poster sign. So I walked in the room, stood in the back of the room, and he started talking to these doctors, and it's almost like he's talking to me. There was no one in this room but me. And so at the end, I went up to him. I said, hi, Dr. Marriott, my name's Bob, and I killed somebody. He goes, don't you ought to call the sheriff? I go, no, sir. I gave guy lidocaine. He died. And he put his arm around me. He goes, young man, probably everybody in this room had experience just like you have.
Yes, absolutely.
And that's why they're here is to learn. I said, Doc, tell me how not to kill someone again. He goes, first, you're a paramedic, right? Yeah, first thing you need to do is put the limb leads back on the limbs again. What was he talking about? How did he even know that? Well, see, he understood because he's taught residents over the years that in order for EKGs to be right, you got to have the leads in the right place. If you're just throwing them on there and don't really care, then things happen. But if you run a diagnostic EKG, then you can tell things from it. No one ever told me that before. None of my instructors or anything ever told me that.
Yeah.
So sometimes you got to go outside of your area to find things out that no one's ever said.
I'm going to interrupt you right there because it's actually a good example of a paradigm that exists in EMS, which is we tend to have institutional knowledge that comes from sometimes the lowest common denominator within the institution. Like people will, and I don't mean that to denigrate people out there that are practicing, but a lot of people are just learning from providers, and it's like a game of telephone, right? Where a provider provides information that they learned that's good information. They teach that next provider who teaches the next provider who teaches the next provider. That started out as place the limb leads on the limbs, perform a 12-lead ECG, and by the time we've gotten to the 50th, the 70th, the 100th provider, we've diluted that information down, and the leads are on the chest, and we're kind of maybe even skipping 12 leads, although that's not as common now as it was back in your day. I mean, that was a novel concept, was performing 12 leads on patients routinely, right?
Well, I got to say, though, we didn't have a 12-lead machine. We were moving the leads around with our LifePak 5s and our LifePak 10s.
Wow.
Moving the leads around to emulate the V-leads because they only gave us a 3-lead monitor.
Right.
So we actually had to emulate. In fact, the very first one that came close was a LifePak 10, and they had a little adapter that you plugged 3 into it, it made 4. So you could change the limb leads with a little adapter that went on there, and you had to hold the record button down for 2 seconds to enable diagnostic mode.
Yeah.
And it took out the filters.
But what's happening, though, and I think it's still a problem, although it's getting better. Actually, I don't know how big of a problem it is right now, but it's been a problem where people actually don't have access to expert information in the field of EMS, right? We tend to have in-house training that is training that exists within a specific paradigm that's not necessarily influenced by experts, but essentially it tests the agency's institutional knowledge, and we often aren't hearing from someone who holds the highest quality body of evidence and knowledge in their hands, right?
Right. And sometimes you got to go outside your organization to find something that's different, because no one wants to rock the boat where they're at. They get used to doing it one way, like you said, and that's the only way they can be done. So when someone from the outside comes in, and many books have been written about this, most significant change happens from the outsiders. I don't know if you probably did the Joel Barker book, The Business of Paradigms.
Yes.
Yeah. So he actually says that most things change from the outside in. You recall the story he talks about at Eastman Kodak?
Yes.
Where they had the chance to do Xerox? Yeah, isn't that something?
Yeah.
And so it just goes to show you the power of a paradigm, like you mentioned, about locking you into one way, and before that can be the only way you do it.
Yeah.
And so you miss out on great opportunities.
Sure. And it's only just because, and it being the only way you do it is simply because you don't know of any other way, right?
Right.
I mean, we're not like gaslighting providers here, but you
No,
just
not at all.
don't know what you don't know, right?
Right, and that's what happened to me. I was never taught anything about a fascicular block or a bundle branch block or anything like that. To me, they didn't even exist. I didn't even know the structure that they were.
Yeah.
So I walked right into that one. My ignorance got me in trouble. I thought I knew, and you go long enough where nothing happens, suddenly something does, and you're like, oh man, I can't believe I did that. And it hurt. It left a very deep scar, but the only reason why I'm here, I think the Lord redeemed it by saying, go teach others. So he put my feet on this path. And so if there's something that's common sense that we're not being taught, I'm trying to do it.
Yeah.
So 12-lead was first, capnography is then, and now we have manual ventilation, which is another thing that for years, the bag valve masters are 70 years old this year. The Ambu bag, it's made by Ambu, they invented it. So the Ambu bag is 70 years old now.
Wow.
And so it's a device that we've mastered. Just so happens the 12-lead is still about 75 years old, because it came about in 1952 when they made the first device that could run 12 leads at the same time. Yeah.
You mentioned not knowing anything about fascicular blocks.
Yeah.
And I mean, I know about fascicular blocks, and the reason why I know about fascicular blocks is because of Bob. In my mind, I can see the Xerox copy of the graph of the leads pointing like up, 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 and then up, intermediate, and down, and then up, down, down, and then down, 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 and I remember it saying, which ones were the fascicular blocks, and it had the information on patients who were experiencing ACS who had these vesicular blocks having worse outcomes,
Yes.
and that was incredibly influential to me to have this knowledge in my hand. I felt like I had power. I felt like I had information that could guide my treatment. Not only that, but it was impressed upon me how important it was to have that information because of the outcomes these people had when they had these vesicular blocks, when they were experiencing heart problems.
You're right. And the adult learner needs two things to catch on. They need to understand why. Like you explained it perfectly right there. You ought to teach my class. So, but you explained it perfectly. It means something to you. And then the other thing you need is clinical relevance. So here's why the combination is important. Back in the day, I didn't know what it was, so I had no point of reference, but I had no clinical relevance at all. So why would I do something if I watch someone do a little thing that shows you how to quickly diagnose this condition if I didn't know what it was and didn't have any clinical reference?
Sure.
So what we do in the class is we teach them what it is, how to find it, and then we teach them clinical relevance by showing them actual cases.
Yeah.
So at that point, right there as an adult learner, you say, I got it. And it's important to you, so you start doing it.
Right.
Because you got the information and you got the relevance.
Yeah.
So if adult learners don't get both of those, then you take them half the way.
And the clinical relevance is a big deal too, because there are people that don't even understand what the clinical relevance is, and so they'll learn that information even if they're kind of evidence naive. You'll teach them to that and they'll memorize it, but they don't know what to do with it.
You got it right. They memorize stuff for a test, but they don't understand what it means clinically.
But then there's people who tend to be more skeptical, and they hear information and they tend to kind of be resistant to it because they've developed a certain amount of cynicism.
Right.
They've been in the field for a little while, and so they want to know the clinical relevance. And I can remember I was trying to teach somebody axis deviation, and they didn't want to know anything about it because they didn't understand the clinical relevance. And I've struggled for a long time to impress upon people what the clinical relevance of axis deviation was. So, like, this doesn't mean anything to me. I don't know what to do with it. And so one day, this is after the inception of Google Maps and when Google Maps became very popular, I was like, just imagine when you're looking at a traffic pattern and suddenly you see that traffic pattern disrupt and it suddenly becomes red down the main road that you're traveling, right? And so you start seeing traffic patterns go in other directions. That's telling you that there's a problem on that main highway, right?
And have them divert the flow.
Yeah, and so when you learn axis deviation, you're learning that there's a traffic problem with your electricity and something's causing that.
Yeah.
And that can lead you to start creating differentials. What is causing this axis deviation? And that really clicked for me, was being able to understand the power of the clinical relevance of that information, because you can learn things simply because you're flexing on learning those things, or you can learn them because it means something, right? Yeah. Something I want to give you credit for, because when you started telling the story of the person that you gave lidocaine to, you threw out a lot of stories that sounds like you came out of like a movie like Mother Jugs and Speed, where you're just holding on for dear life and kind of just like really something that would be like the evidence-based practitioner's worst nightmare, right? I want to give Bob credit in that Bob is one of the most evidence-guided people that I know. And Bob has always, always, always pivoted to better information whenever it is available to him. And he is a model of what it is to be a veteran in the field and still be moldable and malleable and open to better information. In fact, I have peers who, when they've seen me create content with Bob, they've said, hey, something Bob said didn't exactly jive with me. Can I contact Bob and talk to him about this? And I've actually connected them to Bob, and Bob has pivoted to that better information. And I just wanted to acknowledge that this is exactly what we want out of our veteran providers, and what Bob teaches on a daily basis is here's better information for you to have. And so Bob not only teaches this, he actually lives it.
Yeah, and you have to. I mean, if you're going to be believable for different people, if you're going to be believable, you have to have that. And you have to be able to take the data and explain to them well they can understand that. Just throwing data at someone, it goes over people's heads. But if you can digest the data and give it to them in a way they can understand it, it works a lot better.
Yeah. So how long did it take from that incident for you to really develop fully the MultiLead medic?
Well, it took about 7 years, and to further the story, I went to saw Dr. Marriott. Then I started changing the way I was doing things, and learning different things. Back then, there was no internet or anything like that.
Right.
So I had his address. I'd write, and I would get his staff to write me back. So believe it or not, I actually got a schedule where he's speaking at. I started being a groupie. So I started going to these places all over the country to learn from him. And so finally, he said, I've seen you at 3 or 4 of my conferences. Should I be worried? I go, no, I'm just trying to learn. I want to do something. I want to teach this one day. He goes, well, I'll help you. Look, from that here on out, just send me this information. Here, send it to this address, and I'll get it personally. Mm-hmm. So the thrill of my lifetime came in 2000. A buddy of mine in South Carolina knew my story about Dr. Marriott. Well, it was a combined clinical conference there in Myrtle Beach. And he said, you're going to be doing a cardiac talk. You're going to be sharing the stage with another speaker. We haven't got it confirmed or anything. So who is it? Well, it's another paramedic speaker or whatever. But they just kind of blew me off. I go, okay, so you'll do some, they'll do some. Cool. So I'm up there getting set up. Still don't know who's speaking, right? Here comes Dr. Marriott walking in. He goes, hey, fella, how you doing? It's you and me today. I go, really? He says, but I lost my laser pointer. I go, here, use mine. And so I got to teach with him, and that night he drew on a napkin how to do bundle branch blocks, how he come up with the criteria, because he's the one that did it. And like an idiot, I learned it, and I could explain to people, but I took the napkin and put it in my pants and I washed it.
Oh, man.
I had original research there. So right before then, though, Dr. Marriott went to the HA headquarters back in 1989. They were about to do the national HA for the first time. And he says, I'm going to go down and try to have them get out of Lead 2 and go to MCO1. He had all the data. He was going to give them that module. If you just quit Lead 2 and go to MCO1, and they told him
it's that modified chest lead.
Modified chest lead 1. Yeah, it was called the Marriott lead from nurses.
Okay.
And then EMS, he corrects his nurses, say that's not a chest lead, that's a modified chest lead. So it's called the Marriott lead. He got credit for it, but his nurses actually did it.
Okay.
So he sent me a postcard from Dallas. He was at the headquarters, and he wrote on there, Bob, I tried, unsuccessful. Your turn now, Barney. On the postcard. And so he sent it to me from Dallas. At the time, they were about to implement the new 1990 guidelines. And so he tried and failed. So when he told me that was my mission. He said, your turn now. And so I go, now's better than any other time. So I started teaching MultiLead medics in 1990.
Wow.
And so now it's in its 36th year. And how can a class go that long for 36 years?
Right. And you're still teaching MultiLead.
Still teaching MultiLead medics, yeah.
But
36
you've updated
years.
the information.
I've updated the
right?
information. Some of the things I keep in there for legacy. Like the MCL1, I still get that slide in there. The story's legacy, the first story ever told. I still got the rhythm strip where I killed that guy from. I still put that in there.
Really?
That's perspective.
Wow.
And so what I tell people is perspective means everything, and here's mine. So I explain to them my scar, and then they understand that I'm human too, and I made a mistake, but that's how you recover, is that you have a mission that you try to make things better after that. Mm-hmm. And so that's, like you said, you hit it. Scar is the thing that motivates you to do things.
Sure.
Or it can make you hide in a corner.
Right.
So that adversity, how you handle that is the key, I think.
Yeah. I can remember responding to a chest pain, and it was everything about the dispatch information sounded like I was going to see a STEMI, even before I got there. And before we got to the house, they had actually met us out on the road, and when they saw the ambulance, they pulled over and waved us down, and the guy got out. He was clutching his chest, and you could just tell by looking at him, like, this guy is having a STEMI for sure. Got him in the back of the truck. I got him hooked up, did the 12 lead. Don't know what my lead placement was like, I don't know if it was good or not, but I didn't see any indications that he was experiencing a myocardial infarction.
Right.
And so I convinced him to go to our local community hospital, which was less than a mile away. And he did not want to go there. He wanted to go to the cardiac center that was 20 miles away. It wouldn't have cost me anything to do that, but I convinced him to do that. We get there, and they put him on a 12 lead, and I mean, he has elevation in leads, 2, 3 AVF, reciprocal changes in 1 in AVL, elevation in 3 and 4 and 5 and 6. He probably was left side dominant, and it was just unbelievable to me. And, I got into a lot of trouble for that. I was the one who had to end up transferring that guy to the other hospital. And I probably cost this guy some heart muscle.
Right.
And that is one of the first scars that I really had to carry with me in EMS, was just my inability to follow up on my own sixth sense, that I knew what was going on this guy, and I don't know why I wasn't seeing it, but that didn't mean that it wasn't there.
Right. Well, sometimes they try to technique that out of us. They try to Sometimes they try to protocols out of that, and so people think it's protocol or nothing. But being able to think about what you're doing, protocol can't tell you everything to do, and so it's a guideline. You should follow your local protocol when it comes to treatment. But patient assessment, decision making, there's not a protocol for that. That's what you have inside here. So never learn things to memorize a protocol or a test. Learn things to take care of a patient.
Yeah.
And when you talk about, I can't believe this, but they talk about first pass success rate. First pass success rate. Like, okay, you want to pass them out of class, but do we really know the clinician they're going to be? So what do you call the doctor who finished his last in medical school?
Sure.
Doctor. What do you call the guy that took it 6 times to get his paramedic exam? He still passed it.
Yeah.
Doesn't mean he's worse than the guy who passed on the first time. So when we focus on playing a memory game to pass a written test and not clinical stuff, then there's no way they're going to get it. I taught paramedic students for 25 years, and I never gave them a study guide or anything like that. My students didn't fail. Because if they understood what the objectives are, they'll answer any question put up to them.
Yeah.
But when people try to memorize the answer to the exam rather than understanding the concept, that's what makes it hard to take a test.
Yeah.
And granted, there are people who have a hard time taking tests. I get that. But for the most people, it's that if you understand the condition enough to repeat it back to somebody else and not just memorizing it, you can explain it. And see, I know you're that person. You've done that for me several times here. You turned around and explained it right back to me in language that you understand and it's true. So if all of our students and people can do the same thing, then they're going to be great clinicians.
Sure.
Yeah.
Yeah. I mean, and it's part of that principle of learning. What is it that you listen once and then you do once and then you teach once?
Yeah.
Right.
Do once, see one, do one, teach one.
Right. Yeah. And that's a powerful way of learning. So take us now to the time where you're doing Slap the Cap, because you are like the OG when it comes to influencing EMS on the value of capnography. And it is like capnography, we're still really only on the cusp of what capnography tells us,
Well, in the early 90s, I was at Mass Ambulance in Kansas City, a high-performance system, and I went there to follow Mike Tagman, because he was another mentor in the field, follow him and some other folks there. So I went to Mass, high-performance system, and the first thing when I got there, the very first week, we were beta testing a device that you put on an endotracheal tube and it turned yellow whenever a tube's in the trachea, and purple if it didn't, right? So we got one of those. We did an in-service on it. And then we're 20 minutes outside the in-service, and the people that trained us from the company says, we have no human data. We just blew into the lab. You guys are doing the first testing on it. So I may be the first one to actually use a color change device. I can't verify that, but I think I am. So I'm working a call. I got a cardiac arrest 20 minutes after that class. We're on the streets, down the docks. I get there. My partner says, we're going to use it? Yeah, we're going to use it, Doug. So back then, we intubated first, ABCs. So I got in there, beautiful tube, just passed the cord, got him in there first attempt. Blew up the cup. I said, give me that device. He gave it to me. It's already yellow. But we hadn't done anything yet. Give me another one. So he gave me a second one. It's purple. Put it on there. Squeeze, squeeze, squeeze. Good chest rise, everything. But this thing's still yellow. It's still purple. I go, this thing ain't working. Give me another one. So he threw me another one. I put it on there. Did the same thing. It didn't work. I go, I even looked again to make sure. So this device did not do what it said it was going to do. It stayed purple. It didn't work. So I got done with that one. Then we had a meeting 3 months later, and I had 4 cardiac arrests that didn't turn color on. But the tube was in every time. Then we got our little meeting together, and some of the other medics had the same problem. And they said, we didn't have one single case where it worked in cardiac arrest. So we said, well, it does work on dead people. I did have 1 or 2 nasal tubes. That was kind of cool with purple, yellow as they breathe. I go, that's cool. I can put it in that way. So I liked it on that, but it didn't work in cardiac arrest. So we were done. We used, I think, 300 of them in mass, because we're high performance. We used 300 of them, and it didn't work in any cardiac arrest. It worked a few in a couple other cases, but it worked then. So our emergency physician advisory board, remember, this is University of Missouri, Kansas City School of Medicine. So they were doing this, and our advisory board says, we're not using them anymore. They're not ready for prime time. They actually told the company that. They're not ready because they don't work. And they said, well, in cardiac arrest, probably there's not enough carbonic acid coming back. And we said, I thought you said it picked up CO2. They go, no, it's carbonic acid. It's a litmus paper. And so I said, well, what about if they have carbonated beverage? Won't that turn it yellow? They go, yeah, it will. And we're going to have to work on something about that, because you could turn it yellow out of the stomach.
Yeah.
So there's got to be some device to make you differentiate whether it's in the stomach or not.
Right.
So turkey baster. They actually admitted that to us before they even put the device out. Now, Now remember when they said you got to have 2 confirming devices?
Yeah.
That's the color change and the turkey baster.
Wow.
And those were the 2 confirming devices. So when that came out, we just had to laugh. And the other thing I had to laugh about was, remember, this was in the early 90s when we had that. The other thing I laughed about is when the real capnography actually came out. Some were calling it capnography, but it was a color change.
Right.
That's qualitative capnometry, not graphy. Graphy is a waveform.
Right.
So, and then you can tell when people got on the capnography bandwagon because they said waveform capnography.
Right.
That's like saying pizza, pizza.
Right. Yeah.
And so when people say it, I go, oh, I know what they're doing. That's a play on the word. So even big organizations aren't going to change until they see a lot more data. So it wasn't until 2015 they finally acquiesced and called it quantitative capnography by its real name.
Right.
But you see, to this day, 85% use it only to confirm tube placement.
Yeah.
So, but back to the capnography thing, you saw that right there. So that was one thing, and it didn't work. So I was on the ground floor, so I thought, okay, that's the end of that. A few years later, during the mid 90s, when we had Desert Shield, Desert Storm, some of the physicians at work were coming back saying, we got this new data on head injuries that were hyperventilating the hell out of people. And we did that too. I mean, PHTLS, ITLS all said hyperventilate the injured patient.
Absolutely.
We didn't know what we were doing.
I had 3 years of EMS education that reinforced that I should be doing
yeah, exactly. And we understand why we were doing too much.
Right.
So there's this new device came out. It was we call it the green machine. It was a handheld device that only measured the rate and the CO2. It didn't have any waveform. Mm-hmm. So we saw that. It was brand new. We would be the first in the world to get it. And so, okay, we're going to order some, but they weren't even out yet. So when it came out, we got them, but I never got them at an EMS office. I worked for a hospital-based system. So I called purchasing. I go, where's our capnograph machines? Where's our capnography machines? We ordered them. They go, it's in the anesthesia. What's it doing in anesthesia? They have control over that. We don't. I go, we're EMS, we ordered it. Yeah, but you're a department of the hospital, and that committee overruled you. Mm. So I went up there to anesthesiologist. I said, hey, you got our capnometry? Yeah, I do. Okay, can I have it? He goes, sit down, close the door. I saw this come across there. You're about to use a tool that we use every day in the OR, but what experience do you have using it? I go, none. I just heard it can measure CO2. He goes, that's exactly what I thought. How are you going to teach this to others if you don't know about it yourself? I go, well, you got me on that one. He says, okay, I'll let you have it when you come over here and be with me until I think you know what you're doing. So I had to go to anesthesia. This was in the mid-90s. Mm-hmm. I had to go to anesthesia, and I had to hang out. I thought I was going to get a 2-hour in-service and get, no, 6 months.
Wow.
And I had to use it on every patient he used it on top of theirs, the whole thing. We learned a few things about it, as we went through the thing as well. Like the original one had to be calibrated if you have too much oxygen. We didn't know what that was. And so finally, when we got done with all this, okay, you're fine. The purpose of getting that device, so we wouldn't have hyperventilate head injured patients. That's why we got it. We had no tube confirmation ability because we had no waveform. Mm-hmm. It was only to control the ventilations. So we started using it, and right off the bat, we had to tell our people to slow down, squeeze the bag slower, not the whole thing, to squeeze it like that. And I learned all from anesthesia. Mm-hmm. So I was learning about the capnograph. He showed me things about ventilating a patient that went. So SCAR 2 was forming, although I could not directly say that I killed someone with a bag valve mask. But he said, no, you got to keep the CO2 just right to do this, and squeeze the bag, not the whole thing, enough to get the chest rise, and on his thing, he had a way to measure it too.
Right.
And we didn't have that in the field. So we took that, and so for 3 years, I applied at EMS Today to do a class on this new device. But the first 2 years, they actually admitted to me, Bob, no one in the committee even knows what it is, because we're the first in the world to have it. Mm-hmm. So he says, maybe some other time. So finally, in 1998, they accepted it. And I did it for 22 people, and 2 of them in the class were from Physio Control. And they said, hey, we want someone to come consult with us about this new device we're going to put in a new machine we're working on. Mm-hmm. So I signed a non-compete agreement, and what was on the board right there is a LifePak 12.
Non-compete or non-disclosure?
Both.
Okay, wow.
Both.
Okay, yeah.
Both. Because why? Because as soon as that came out, I got a call from another monitor company saying, come help us. Mm-hmm. I said, I can't until 7 years.
Oh, yeah.
So 2005, Zoll called me up.
Okay.
So I went to help Zoll out, and I can't say this for a fact, but Zoll had their own little Capnostat 5 thing. Mm-hmm. It was way inferior to the Iridian technology.
Wow. And
so I said, first thing you better do is switch over to Iridian. Mm-hmm. And I already found out from Iridian that this new monitor called Philips is going to have their technology. I said, do you guys make it exclusive where Zoll can't use it? They go, oh no, Zoll chose that. So I go, oh, this is what they're telling me up there at Physio, right?
Yeah.
So I signed a non-disclosure, went up there, and I remember breathing. I had a little computer board there, and there's a little screen on it attached up to it. It wasn't anything like a monitor. So I had the cannula on. I'm breathing through my nose, watching it on the little screen they gave me there, right? And so it's just showing the numbers working out. They had a little waveform. So I was showing that, and I go, this is pretty cool. So I was breathing through my nose on purpose, going like that, right? And so then I started breathing through my mouth, and it went away. I go, that don't work. So I breathe through my mouth, no CO2. Breathe through my nose, I got it back. So I said, hey guys, come here, look at this. These are engineers, right? I go, when I breathe through my nose, I read it just fine. But when I breathe through my mouth, it doesn't work at all. He goes, well, duh, you got to breathe through your nose where the sensors are. That's what the thing is. I go, I can't make someone do that.
Right, yeah.
So here's my role as a clinical, as a consultant. I go, I can't make my patients do that.
Right.
You got to have something over their mouth.
And some of them just won't.
Some just won't.
Yeah.
So they got this little fang thing that hung on my lip. I still got a picture that I took years ago. Maybe I'll send it to you to put up. But I got that picture, that little fang over my lip, and I remember my hair's black and everything else. I look a lot different than I am now, but I remember trying to blow into it, right? And it was working when I blew into it, but when I breathed normally, it went way around the thing. So I had a little bitty hose right here, and it went around it. So I got low reading all the time, low reading. So finally I said, why is it reading low? They go, I don't know, you're breathing through it, right? Yeah, but I think most of it's going around it. They go, oh, okay, we're not sure why it's doing that. And I talked to a couple of engineers at Iridium, and they told me something way back then.
Because it's aerodynamic, right?
Yes, aerodynamic, but they said, also remember this, remember what we're measuring EtCO2. In tidal carbon dioxide. That means at the end of a full tidal volume breath, measure the CO2. Mm-hmm. So if things only picking up 50 milliliters out of the 500, that's not enough volume.
Right.
But things going to read low because they get a sufficient sample.
Right, yeah.
And so
you're not even producing CO2 yet.
Right. And so the first 150 to come out have nothing but dead space. The next 150 have a mixture. It's not till the end of it that you get full CO2.
Right.
So that's why it wasn't working that way. So they finally redesigned the other one. I remember seeing the smoke tunnel test they did on it. So that design you see on those Iridium cannulas there, it's that way for a reason. Now, if I take you back before then, they actually made the thing, and I told them this isn't going to work. They said, well, we don't have time. We got to get it out. And so it's so funny that, not really funny, I don't know the truth behind this or the whole story, but I do know shortly after it came out, it got recalled by the FDA. So maybe that was a godsend or something, I don't know. Mm-hmm. I was actually teaching people in my first capnography class, don't use a nasal cannula. I told them to put the airway adapter on a puffer from a mouthpiece and have them blow through that. And I said, I'm not going to teach them the cannula, guys, because I know it doesn't work. I can't go out there with a straight face and say, use this nasal cannula.
Right.
Because it didn't work. I tried it myself. So I started having blow through that, and a couple people lost their job because they were told not to use a cannula, so they used the other thing, and they were getting in trouble for using the wrong thing because they took it in the class, but it worked. So anyway, I saw the smoke tunnel test, and as the air goes out this thing, it's solid right here, then it's curved over. So it pulls the air in, but the smoke, as you see it go around, it came back like that. Because the Venturi effect created by the shape of that design, it pulled it back in. So what's interesting about that is the brass ring is patented. Okay, that was patented at the time, so no one can make a compatible device other than the Iridium. Well, the brass ring patent wore off, and so everybody started jumping into the aftermarket capnography devices. Mm-hmm. And so the thing about those is they can't have that design because that's still patented.
Oh, wow, okay.
So these little dangly things that look like it, they're not the same.
Okay.
They're not the same. So what's happening, people that use those devices, and I found this with my capnography classes, I go to like hospitals and they say, well, we try to use it, but it reads low all the time. So I go look what they got. They got a split nasal cannula thing where it picks up CO2 one and the oxygen out of the other.
Right, yeah.
And so some other things we found out was that if you give them oxygen up this one, it mixes with the oxygen in there and lowers the CO2 because it dilutes the sample.
Right.
So if oxygen going up there and it's measuring CO2 out of the other one, it's not going to work. But the third generation devices now for capnography deliver oxygen through little holes around it.
Right, it's
but
essentially
not up the
delivering FiO2 and not flow.
Exactly, exactly. So when they breathe in, which is how it's got to go in anyway, because you can't ventilate someone with the nasal cannula, so it's got to come in and they take the breath in, it pulls the oxygen down there. So it works that way. And so again, something that at the time they weren't even thinking about. But when you do reality-based medicine, where you go see how it actually works on people, we find different things. We found that people with a big mustache or a big upper lip, it pushes the thing out that way. So when things sticks out like that, all the air goes underneath it, and it can't be picked up.
Yeah, yeah.
So who'd have thunk it? Put a little surgical mask on them, it keeps it flat against their face.
Yeah. Or you can put some tape there or something like that.
Well,
Right,
I've done tape before.
Yeah.
I've had people, look, if you do that again, I'm just going to do it. So they roll it down there.
Yeah.
So you can do it that way, but if you just put a little surgical mask, a little, over their ear thing, it'll hold in the right place. So, and we found with N95s also. I'm
going to crank our little time device here and put us a little bit farther into the future now to where we are right now, because what you're doing right now is you're involved in essentially kind of, well, you describe to me what you're doing right now, what you have going on.
Yeah, the Manual Ventilation Academy, the reason why I do that, here again, I mean, at my age, I've done the capnography, I've done the 12 lead, did a stethoscope class too, but what am I doing this for? Well, as I watch what's been going on about we do too much, we too big a BVM and stuff like that, and these are people who are smart enough to know better. You know, as Joel Barker said, even experts get caught up in the data where they can't see common sense. You know, so I can't believe we're saying that people in cardiac arrest don't need to breathe. You know, I thought air goes in and out, blood goes round and round. What evidence do we have that we somehow have evolved to hold our breath 5 minutes? So when they started to think about just doing compressions, well, they had better outcomes. Who had better outcomes? And how do you randomize a dead person, someone who did it with CHF, someone who has normal heart and lungs? How do you randomize these people when you don't know what's wrong with them? So the witness cardiac arrest, we get great survivability, but the unwitnessed has been down for 10 minutes, it's kind of bad.
Well, isn't cluster randomization supposed to account for that, though?
It could, but how do you know who's what? Because you could have 100 CHFers and one normal person. So if you cluster them without knowing their diagnosis, I mean, yeah, you can get a randomized sample, but what if this sample is tainted with so many people with that one condition? So that's one way to do it. That's when you do it when you don't have any other way to randomize by pathology. So you got a dead person. We don't know dead person with what to put them to randomize them. But if you get same, apples to apples on each side, then that's the same thing you're saying. But you can't study apples to oranges. When they say outcome studies, are people doing better than yours? How come? Well, we put a supraglottic in, not an endotracheal tube. Who's to say that piece of plastic did that? I think it's a ventilation. Because why do you get an airway? So you can ventilate. You can put a perfect airway in and overdo the ventilation or underdo the ventilation, and the outcome's poor. But up until recently, we didn't have the ability to measure ventilations that we were giving. We had no way to measure what the patient was getting. We just went by, okay, they got it and they lived. They got it and they didn't live. But the study by Idris and others in 2023 showed that people who were better ventilated had better outcomes. And not just better outcomes for survival of discharge, but CPC1 rates. They had better outcomes neurologically. So the common sense on that is this. You get two people in cardiac arrest, if you're going to randomize them, right? Both of them were down for 5 minutes. One person got 5 minutes worth of compressions only, and they survived to hospital discharge. The other person got 30 to 2, and they were ventilated during that time. Which one do you think had the better outcome neurologically?
30 to 2.
Yeah. Ring. So what does that say about the studies that say that they do better when they aren't ventilated? There's no validity. Now, until the Idris study came out, everybody believed that. You see what I mean? So to me, I took that as we suck at ventilation. So let's work on ventilation. So initially I did it with a Laerdal Simman 3G with a...
Let me interrupt for a second, though, because where we have tried to account for this and take the person out of the picture has been going to PDBVMs or with specific new types of styles of BVMs and we have essentially tried to take the human factor out of it, and that has been wildly unsuccessful. The data has come back on PDBVMs and cardiac arrest, and it has been found lacking. And so now what we're really doing is focusing in on actually understanding what we're doing when we're ventilating, what kind of tidal volumes we're putting in there, and trying to actually perfect the practice of ventilation.
And what they were doing, Jimmy, they were breathing in test lungs. They had a test lung, and this is the pediatric BVM they cited in the study. This is the Ambu Spur 2 pediatric BVM. This bag holds 682 milliliters. Okay, that's what it holds. So if you're going by the data, published data, AHA says 400 to 600 milliliters tidal volume. European Resuscitation says 6 to 8. Okay, if this is 683 and the most you're going to give is 500, shouldn't this work?
Sure. In fact, a lot of the recommendations, even with Seattle, they don't, with high performance CPR, they don't recommend any more than 300 to 350 milliliters of tidal volume, which I can deliver if I have this hooked up to a test lung, right? All I got to do is squeeze the bag, right? But if I have on a mask, if I have any leak whatsoever in this pediatric mask, I may not get anywhere near that tidal volume.
And it's not just the mask, Jimmy. Look, if I were to pour water in here and stop at the end, by volume displacement, this holds 200 milliliters. So you squeeze this, 300 comes out, but 200 get caught up in there.
1/3 of my volume is in this mask right here.
And it never got down to where it needs to. And remember, then you got 150 dead space to get to the alveoli. So that's 350 just to get there. If this only puts out 300, there's no way. And see, common sense bell, ring the common sense bell.
Which means you're just basically trading dead space back and forth, right?
Yeah, it's also you're doing dead space ventilation, which don't ventilate at all. So the CO2 never gets out, the oxygen never gets in, but you seem like you're doing okay because But that's what I mean. So they wouldn't have known this until they got a device like this EOLife X that goes in between here, and you squeeze the bag, and that's actually measuring what they're getting. So one thing about the X that makes it work is as the air goes through here and goes into the patient, then it comes back. When it comes back, it's got to cross this sensor, and that's tidal volume. If you squeeze the bag and all goes out the mask seal, some devices will actually say, oh, you got a good ventilation, but not this one because it's got to go down and come back. It's true tidal volume.
Yeah.
And so in my other device was the SimMan 3G with the ASL 5000 lung simulator. It's the highest level you can get. And I could measure going back and forth because the device did. And so I could do that. Then this EOLife comes along, and now it's portable. And so before, there's no way the state of Virginia would let me take my simulator on the road with me. So whoever come to my class, I could show them on the simulator how well they're doing after they're done. But when these devices came along, now I got a device I can do a class with because I can take this on the road along with these Ambu Man airway mannequins, which have an intact airway, and that does the same thing. That allows the air to go in and come back like a real person, and this is the device to measure. Mm-hmm. So that way, what we do in the Manual Ventilation Academy is we do point of care measurement. So this is not in a test lung. It's not on an RQI mannequin that goes out another hole. This is the same place like we do a real person. Mm-hmm. You know, people, air goes in, it doesn't come out a valve on the side. It comes right back up their airway again. So whether you got an endotracheal tube, or supraglottic, or mask, this thing will measure the tidal volume at the end tidal.
Right.
And of course, the capnograph you put on there has to be in line, so you're measuring that. But like we said before, first thing you do is get this ventilation correct, because the ventilation is correct, then what the CO2 is reading is in tidal. So that way your capnograph depends upon the volume being right. If the volume's too much or too little, it could be off as well. Mm-hmm. And speaking of capnography, this is the other thing, and this is a horrible mistake that people make. Capnography is end tidal CO2. So if someone squeezes the bag faster, we think they're hyperventilating, but guess what? We're moving dead space. What's the CO2 going to do? It's going to drop.
Right.
Okay, so what do we call hyperventilation? You blew off all their CO2.
Right.
So people are going to think that you're hyperventilating because you're squeezing too fast when actually it's dead space.
Right.
You're
just not producing enough CO2, right?
Right. Well, it's not coming out.
Right. Yeah.
It's
you're not
coming
seeing
out.
it. Yeah.
Right. So the faster you squeeze the bag, it's just going to move dead space because anatomical dead space is always there. So the faster you go, you're just moving dead space faster.
Right.
And if you squeeze fast, you can't squeeze deep to get it down to the alveoli.
You're playing just like playing with a yo-yo with dead space, right? Yeah.
Yeah, and so it takes a tidal volume to do that. So what we do in the academy is we teach them the importance of measuring tidal volume and rate and things like that. But here's the other thing we do. It's not just can you do it, what if you're messing up? So we teach them how to hold a mask seal different. Mm-hmm. Like I had several people come to the booth today, and they were seeing that, and they were trying the EC technique, they weren't getting it. So we show them another technique where they put their thumbs on the mask like this, and then they pull the jaw with their fingers. They pull the jaw to the mask.
Right.
And then when you're holding it this way, then that's the position of function for your hands.
And that's the important distinction to make with that mask position, is that a lot of people are trying to push the mask onto the patient when in reality you're pushing the patient up into the mask.
Yes.
Right? Yeah.
And also at the same time you're doing a jaw thrust. So we broke down this skill of BVM ventilation. We know there are 4 tasks that must be performed simultaneously for the breath to go in. Number 1, you got to hold a manual airway maneuver. So you got to open the airway, head tilt, chin lift, or jaw thrust to open the airway. When you open the jaw, it does that. Number 2, you got to hold a mask seal that doesn't leak. So you can do both with this. Thumbs this way, do the jaw thrust and tilt their head back. Mm-hmm. And so you can do it this way, but if you're this way, you don't have enough leverage to pull things back. So people that sit above or pushing down is all they can do. Like you said, you smash the mask against their face. Mm-hmm. But this way, you have to pull this to tilt back.
Yeah.
So this way here works really good, and we have the trials in the academy to prove that. So you can do it this way.
And no one should really, I mean, aside from when you have not enough resources, at this point we shouldn't be one man mask ventilating, right? Mm-hmm. It should be a 2-man operation, right? Somebody holding the mask, somebody performing the ventilation, right?
But what if you got 2 people and one's doing compressions?
Well, that's what I'm saying. In a low resource environment, there's nothing you can do about that.
Well, yeah, there is, because let's say, for example, you got that scenario, a 2-person pit crew, right?
Oh, you're talking about one person compressing and then at the break,
they raise and squeeze the bag. So we show that in the academy, and when we measure it, people do perfect every time that way.
Yeah.
But the people trying to do this with one person have a hard time doing it.
So the technique is that you have a compressor that's doing their compressions. This is for 30-2 ventilation, and then the person that's ventilating actually holds the mask on the patient. And then if Bob were the one doing the compressions, when it comes to the break,
between 9 and 30, now keep my place with one hand, squeeze, and get back on the chest again.
Yeah.
So that way you have a perfect mass seal, and your compressor does the ventilations.
Yeah.
And so you both can last a lot longer that way.
That's right. That's right. And you're doing something that is providing a superior airway experience for your patient as well. Yeah.
And the other thing was, that's the first two. So mass seal and hold the airway open. Then you got to squeeze the bag just right. So when you squeeze the bag, you take 3 fingers and 1 thumb like this, and you squeeze it till you come together. And then look on your feedback. If you're in the green right there, then what that tells you is that squeeze right there gave what you wanted to give. And so in the academy, since we have the feedback continuously, sometimes they'll do too much, sometimes they'll do too little, and so they can slide their hands and get it just right. And so what that does, it gives them feedback. And this is where muscle memory is developed at. You do this, and you get feedback that says that was good, then it goes to your brain, and your brain and your hand are communicating. So you do this to get the right volume. Also, you got to do this for the right timing. So those are the last two. So these 2 skills here, hold the mask seal like this and open the airway. Those are the first 2. The other 2 are right here. These skills here, where you hold the mask seal and open the airway, these are durable skills. These are durable muscle memory skills.
They are.
If you master those don't go away. I mean, I don't know when you started, I used to do a head tilt neck lift. And to this day, I'll go to a mannequin and do that because that's my muscle memory.
Right.
But I know to quickly do this. But I was taught that way. The other 2 here, these are fickle right here. These skills are fine motor skills, and they will go away after a week or so. So when he talks about muscle memory, that's great. You use feedback to develop muscle memory. I've had people that go through the academy class, they ventilate 100% when they're done. So I go back to them 3 months later, and this is what I did in Virginia, 2 different places. So both classes had the same people in the class now and then 3 months later. So what happened was, we went in there, they did their ventilation, got 100%. I went back to the same place 3 months later with the same people. One subset of them, I had them ventilate blindly so we can see how much they've retained. 3 months later, the best they could do was only about 60%. Without the feedback, they got 60%. So their muscle memory for this held up, but this did not hold up. Then I would let the other group have the feedback immediately when they did it. Come to find out, after 2 breaths, they're all 100% again.
Wow. So
what we know about that is, and I did this part of my master's project before I even knew about what I was going to do here. So what we found out was durable skills can last months without even remediation. But fine skills, after about a week or so, they start to deteriorate. But here's what we know. If it's a fine skill, with feedback, it's easy to recover to get that skill again.
Sure.
But without feedback, it's going to take a little bit longer.
You may not even know that you're performing at a low quality, right?
Right.
Yeah.
So wouldn't it be great if you have the same device you used on training on a real person?
Right.
See, there's solutions out there that take you half the way. One of them says, well, we give you feedback when you're training, but after that, you're on your own. But they're relying on 100% muscle memory to prove it.
Yeah.
But my studies show that muscle memory for this doesn't last long, and this is what it's all about.
Right.
So we can teach you how to mask skill right, and we do that in the academy, but we do more than that. We show you how to squeeze it right at the right timing, guided by feedback. And so now we can correct that problem.
Right.
And so, again, you don't know what you don't know. As we're trying to squeeze the bag, we don't know if it's going in or not unless you measure it.
Right.
And so that's, again, this is right up the alley of almost everything I've done in my career, is to help people who didn't know that know that.
And this is really important, because the dynamics of ventilating somebody is doing something in the chest, right? When a person is alive, they have this thing called the intrathoracic pump. And so when I breathe in, it exerts pressure against my left ventricle. My lungs exert pressure against my left ventricle, and that helps with cardiac output. It gives the lungs a little bit of a pressure, or it gives the left ventricle a little bit of a pressure assist. When I breathe out, it allows some room for the right heart to refill, and that assists with cardiac refilling. Somebody who's in a state of cardiac arrest, that natural physiology isn't working, and so if you can really screw up that intrathoracic pressure, and you can exert way too much pressure against the heart so it doesn't refill, or you cannot exert enough pressure against the heart and you can actually make it so that the heart's not actually ejecting enough blood. There's a very careful balance right there that you have to maintain, right?
Yeah, and what measuring does, it helps you perfect that. And so some may say, well, we're going to control the flow that goes in, but even with that flow control, you can still do too much. You can put a device on here, if I go like that, it'll stop it. But if you put a device on, I go like this, I can put 1,000 milliliters right past it. You know, or you get a smaller device, it doesn't get enough. You know, so whatever device has ever been made, by itself, without feedback, it can't do what it says it does. It can't deliver that, what you said. And that's important physiologically to understand. So that's why we just don't teach them a skill. Like you said, we also teach why. So that's in the academy. What you just said is in the academy. I mean, you're probably a part of it, I guess, but that's in the academy. So see, it's the common sense stuff that you get, that you project in your podcasts. It's the common sense stuff that helps providers.
Yeah.
It's not a quick fix to do this. You do this, you'll be great. No, you take the time to explain it. That's the only reason I'm talking to you.
Right.
Because this is not something you go show how cool things are. It's because you explain it.
Sure.
And so when you do that, you're going to get the adult learners that way. Not by how flashy you are, but how you explain things.
Sure.
So you take a small subject and you go with it. So this academy, we explain exactly that. So people, like we discussed earlier, they know the importance of doing this right. And now they have the way to measure doing that right. That's the best of all the worlds.
Yeah.
And that's how we affect change, is that one person at a time, they learn how to do this. And some people will say, I had a conversation with the medical director, well, it costs too much, it costs too much, it costs too much. Okay, you pay $150 to get an IO access when you could start a $10 IV, and you're saying this costs too much.
Well, it's a one-time purchase.
It's a one-time purchase, right? So that's what you do. So training on devices like this EOLife X right here, if you train with feedback, everybody knows the importance of it, and they know they can do it. So the confidence is what helps people be more confident in the field too.
Right.
The competency you choose. I've had several I talked to today say, I'm head of a training site. I do an AHA training site. I do a Red Cross training site, and the guidelines say you will ventilate to this amount.
Yeah.
Unless you're measuring that, how do you know they met the qualifications?
Right.
So what I suggest is that every training site get their hands on an X. So at the point of care, at the point of measurement, at the point of verification, you can do it.
Right.
And the other thing these devices do is they give good formative evaluations. So you got a person squeezing the bag, and you're watching their results. If they hit a golf ball, you'll see it slice, and so you tell them how to change their grip.
Right.
So this one tells you not good mass seal, too fast or too slow or whatever, not enough volume. So the instructor can look at the outcome of that and say, well, we need to work on your mass seal first. So they get the mass seal down, then they clean that up, and then we see what we got.
Right.
So with feedback and all these parameters, real time, you can correct a user's errors that they may make with this and give them the confidence that they're doing it right.
Right.
You can tell them they did better, but as we said in an earlier video, we talked about the myth of chest rise.
Right.
No. But if you have a device to measure, this thing can't lie.
The myth of chest rise is that chest rise does not correlate with adequate tidal volumes.
Right. Or yeah, exactly.
Yeah.
Well said. So this is why we do the academy. It's to help people perfect that skill, which everybody can do, but without measurement, no one can prove they are.
Right. And the feedback is really, and we're getting towards the end of our time here, but the feedback is a really important thing. And you look at an organization like Seattle that has some of the highest resuscitation rates in the U.S., and one of the things that they truly believe in is feedback on their CPR. Like there is somebody who will be monitoring someone's CPR, and if they're going too fast, they tell them to slow down. If they're not recoiling, they tell them that you need to fully recoil. If they look tired, they need to get pulled off the chest they insist that everyone rotates anyway, but that feedback is very important, and everyone opens themselves up to that feedback. We do need that feedback with ventilation, but you can't, just observing, you can't necessarily quantify what's happening there.
Exactly.
So it's hard to offer that feedback. So having something that can do that for you, and we're moving towards that with CPR too. We have active CPR feedback now, and with the new monitors, they're providing even better CPR feedback. And we're even talking about like transducing IOs to get a arterial waveform so that we can see feedback on our perfusion. So this is an incredibly important concept. Yeah. And I just want to add, this is the EOLife. I'm happy to demonstrate that this is the EOLife. This is the product that Bob is affiliated with right here. But what's truly important is that whatever device you have, that you are getting that feedback, that it's not just about you selling devices, it's about actually implementing practices that impact survival, right?
At point of care, and that's the key right there, point of care.
Yeah.
So if you're squeezing the bag on a mannequin and it says you're doing good, but the mass is leaking all over the place, you have to know that. So when you have a device that measures tidal volume, it goes in and comes back, that's how you determine the mass leakage. If your device only measures what goes out, but not what comes back, then you have no idea.
Right, and that's an established principle of ventilation. I mean, when you have somebody that's innovated and they're on a ventilator, one of the most important metrics that we have is exhaled tidal volume. We want to make sure that what's going in is coming back.
Yeah, and the vents do it that way. And if the airway got clogged up and it didn't come back out, the vent's going to alarm.
Yeah.
But if you do this with a BVM, you squeeze it and you let the airway go back down, it's not coming out.
Yep. Awesome.
And so there's so many parameters there, but having a device to measure tidal volume at the point of care, that's the key, point of care.
Yeah.
We can do it in the test lung all day long or on a high fidelity mannequin, but at the point of care here, where we're just like we're going to do in the field, having that ability. And again, we develop confidence in the academy of doing it, but also they could actually carry that on to the field if they wanted to, with a similar device. But again, the key here is that we're being trained, everybody gets trained to competency levels, and you can only do that by measuring.
Yeah.
You can't improve what you don't measure.
Right.
And you can't do a formative assessment if you don't measure.
Right.
So when you're forming that skill and we test that skill, they're doing it the same way. So that way we have better providers.
Excellent. Bob, we've reached the end of our time. I really appreciate your commitment to excellence, your continued commitment to excellence, your continued commitment to teaching, and even your still continued commitment to learning, and appreciate you spending this hour with me.
Yeah, well, I appreciate it, Jeremy. Thanks a lot, man.
All right. Cool.
Yeah.